Good afternoon, everyone. I'm Dr. Praveen Kumar, Manager, Market Access and Advocacy, SCT India. On behalf of SCT and AVO Alliance, we welcome you to this live webinar series on advances in casting and splinting. And for the participants who are joining us for the first time, a quick introduction about SCT and AVO Alliance. SCT was formerly known to most of the orthopedic surgeons as BSN Medical. SCT is a global hygiene and health company headquartered at Stockholm, Sweden, and has presence over 150 countries. While AVO Alliance is a developmental non-profit organization dedicated to improving the care of the injured in low and middle income countries. This is the second program in a series of live webinars scheduled every Saturday from 1 p.m. to 2 p.m. over the next 2 months. And the topic for today's session is novel splinting techniques in extremity injuries. And we would like to welcome the keynote speaker for this session, Mr. Olaf Kandt, who is a globally recognized medical trainer and an experienced orthopedic technologist from Germany. We are also privileged to have distinguished panelists chairing this session. I would like to welcome Dr. Nandkishore S Laud, who is a consultant orthopedic surgeon at Breach Candy Hospital, Mumbai. I would like to welcome Dr. Rishi Bisht, Senior Consultant Orthopedic Surgeon, National Academy of Medical Sciences, Nepal. And I would also like to welcome Dr. Professor Klaus Dresing, Assistant Medical Director of University Medicine Göttingen, Germany. So today's program, the flow would be, it starts off with a speaker session for around 40, which also includes a panel discussion. That would be followed by a Q&A session. So I would request all the participants to post their questions in the question box below the screen. And at the end of the speaker session, we'll address all those questions to the panel members. With this, I would request Mr. Olaf Kandt to start the session.
Okay. Okay, I hope everybody can hear me. Hello, everybody outside. Yes, my name is Olaf Kandt. I'm living in Germany, in Hamburg, and my job is to be a trainer for taping, casting, functional treatments for sport athletes, for sport injuries, and all the normal problems what the people has. And yes, I do this the last 13 years. And that you get an overview what I do, and I will show you a little bit about me. You see here when I do the trainings in the hospitals or external trainings around the world, all the people are interested in modern casting and taping techniques, but today we are talking about casting, splinting casting techniques. And you see wherever I've been, all the people like it to work with modern materials, but the time is changing now, and we want also not stay in the past. We want also change the techniques, the materials, and we develop more and more the materials that at the end we will give you the best material in the hand that you can treat the patient on the most economical way, on the most effective, cost-effective way, and with a high comfort. And at the end, it must be easy for you to apply a cast. Yes, you see, we have so many solutions also for difficult casts in the operation room or in the ER room or whatever. We can help you, the doctors, to treat the patient better and better, or sport athletes, to help sport athletes or the doctors and therapists to treat them, or to show them the taping techniques, sometimes on the big stage, that the people can say what is taping, what is kinesiology taping, the colorful straps on the body. This is the job. Yes. Let's start with the splinting therapy, and let's start with a little bit in the past. or not in the past, but in the past we have had only POP material, but meanwhile many synthetic cast materials are available. Okay, we have good cast materials, we have bad cast materials in the world. I think I know the most of them, and I work with them also, and I can say decide what is good, what is bad, and yes. But let's talk about POP. POP is cost effective, yes. At the end, you have a richer treatment for the joint, and it's absolutely okay. It is conformability, it's fantastic, but, and here you see the question mark, is when we see today why the customers are willing to change from POP to synthetic cast materials, then we see many points. What's the reason why? One of the point is here you see the white mess. You have, when you are finished with the treatment, you have to clean up the room, your hand, the place where you have been and whatever. The next thing is also the time. The time is the setting time. A POP material takes minimum 24 hours, a whole day to dry, and then to get the 100% stability. And in this time, it's not allowed. The patient has to move the joint. When the patient moves the joint, then the material can break, and then you can sometimes make a new one or whatever. And the next thing is, what many people don't know is that it's not allowed to cover the POP treatment in this 24 hours with a blanket when you're lying in your bed, and otherwise the moisture from the wetness from the POP themselves cannot coming throughout. It's stay in the material themselves. It's go into the padding, and it could be the patient has for a long time a wet feeling, or not only a feeling, also a wet skin, what we see sometimes. And the next thing is the weight. POP material is heavy. It is heavy. It's thicker. It's much more heavy as POP. Yes, it breaks easily. It breaks easily compared to fiberglass. Okay, it breaks not easily when you make it so thick. Then it is also stable, but then you have a problem with the weight. So then, what about water? Yes, when you keep in contact with water, with POP material, we see, okay, this is not the best material when you keep into the water, or when you go through the rain or whatever. What is with the X-ray? The X-ray translucency, you see POP material is limited in X-ray translucency. And that you see here from Germany. This is not only Germany, but now I have a slide only for Germany, that you see splint of POP and synthetic splint in Germany in meters. You see 16 kilometers POP rolls. We use it in Germany, a little bit more or less, it doesn't matter, but you see 266 kilometers synthetic splint materials. That means it was not every time in the past also that the people say, wow, yes, synthetic splint material is the best, and we change it immediately. No, it takes time. That means you have to make your experience with this material. You must trust in this material. You must get so sure, so safe with this material when you work with this material, that you use it, that you like to use it later. That means it takes a little bit time, but when you do this step one time, believe me, with the right material, and then you will never change it back, because you see the advantage from this material themselves. Okay, let me say a little bit about the modern fiberglass splint material. We talk about now about Dynacast Prelude. It has two reasons. Yes, we are. This webinar is also based on SCT company. Yes, BSN SCT company. But let me say the Dynacast Prelude is the most modern cast splint material what we have meanwhile in the world. Okay, I will explain you why. Here you see the difference. The difference in the past we have. I don't talk now all these sentences. This is too boring for you. But you see here in the past we have, when we want to have a splint with POP or synthetic cast, every time we have layers. How many? It doesn't matter, more or less. You see the layers. Meanwhile, we have in the modern cast splinting material no more layers, because we see also disadvantages with layers. We have seen this. We have seen wrinkles, pressure points, and whatever. So meanwhile, we have interlocking performance, knitting fabric. You see it here. Interlocking, many sloops are knitted together, and it looks here like this. Yes, and this makes much higher comfort for the patient, and I will show you a little bit later why. You see, the next point is we have a double padding on both sides. That means here a padding and there a padding layer. And this makes it much easier to apply this tape on the right way. That sometimes you must change the one side to the other side, and when you have here no padding or just the paper or whatever, then it could be the patient has the resin from the fiberglass on the skin. Here you can turn it wherever you want. You will have you will have ever the best padding, the right padding on the skin. Yes, you can open it only on one side, not on two sides. This has the advantage that the fiberglass material cannot slip out when you close it, and it's easier to close it. Yes. And the next point is the optimal working time. That means it's up to you how to, I will explain you also a little bit later. You have different choices to moisture the surface with water. You can change the open time, the working time a little bit from 2 minutes to 5 or 6 minutes, but you have every time enough time to apply this cast 100% and in the right way. And later, you will have a setting time at the end from 15 minutes, and then the material is 100% rigid. And after 15 minutes, the setting process is over. Yes. Yes, and the next point is no extra padding required. That means the padding is there. You need, okay, sometimes when you have a prominent bone, I wrap 1 or 2 turns from a padding roll around this area to prevent swelling problems later. But normally, you can apply this cast directly on the skin. You can use a cotton tube behind of this, but this is much more comfort. But it's not necessary. But when you see the POP material, you need more. You need more padding. You need padding. It's absolutely necessary. You have to bring it at first on patient's body, and then you have to apply the POP material. Here, I will explain you the steps. We will come now to the steps to apply the splint. It's easy to do this. At first, you have to cut it in the right length, then directly with the foil, Then, after measure, close the foil with the clip here. You see the clip. And make sure that not the humidity from the air is coming into the foil and can start the setting process. When you close it immediately, you can put it also for a long time in the corner, and then you can use it also later without a rigid material here inside. Yes. Then take out the splint from the foil, and then you see different options to moisten the surface. You can spray the water on the surface. You can spray the water on one side from the padding, or you can remove the fiberglass out from the padding and put it into the water and squeeze it out. When you spray the water on one side from the padding, then we suggest to squeeze it out in a towel after moisten the surface, so that you have a dry surface, and then you can apply this tape immediately on human's body. Yes, and later, and the last point is, fix it with a bandage. We prefer cohesive bandage. It's the best choice, but you can use whatever you want, cotton bandage, elastic bandage, or whatever. But this is the last point. And at least mold and keep with your hand the patient's joint in the right position up to the indication, so long as the setting process takes, and then you can remove your hands, and that's it. And this is a big advantage in the ER room or operation room. You have no mess, you have no steam, you have nothing. You can clean up the room quickly, and yeah, I think this is really, really good. So now I will show you what is possible, that you get a short overview. I will explain later a part of them, not all the applications. You see, you can apply this cast for the elbow. We have different choices for the elbow, for the wrist, for the thumb, for the wrist again, yes, for wrist and finger, for thumb and wrist, for the finger separate. Let's come to the lower limb application. We have different choices in the L shape, in the U shape, in the long version L shape, in the long version for knee application. Leave the ankle free when you have a patella fracture or whatever. You can apply this here too. Or we can apply a sandwich technique cast from both sides, from both parts of the body, so that you have more fixation than with one application from one side. Yes. You see, this is a short overview I will give you what is possible with modern cast materials. And now I will come to the indication for distal radius fracture, and let's talk about Smith or Colles fracture, and then I will explain you what kind of options do you have when you use the modern cast splint material, the Prolit, for example. What we do, and our experience was really, really good with these three options you have. Let's start. At first, you need the box themselves. And here you see it's also available not on the roll, a 4.5 meter roll. You can also, it's also available in the pre-cut version. That means you have a special length and a special width, and then you open the foil and you can apply it immediately. You must not cut it from the roll, but it's much more economical when you have the roll, when you are in the ER room and you have many, many splints week or in the month, then this version is much more economical. This is when you have more seldom applying splint, then we prefer the pre-cut version. Or you put it in the backpack or whatever for the treatment outside. Yes, and then the bandage themselves, cohesive or not cohesive. We prefer, you remember, the cohesive bandage. Let's start with the dorsal splint, and then I want to explain you what we do with it when we produce a dorsal splint with the prelude material. We measure the right length, yes, and this is interesting. You can stretch the padding. You can stretch the padding in the length. Then the padding is longer than the fiberglass themselves, and here you can prevent sharp edges. This is important. Make sure that never will the fiberglass material is longer than the padding. Then the fiberglass has a little bit overlap here, and after setting, fiberglass is sharp at the edges, and then the patient in the flexion line, wherever on the body, the patient can hurt the skin. But when you stretch the padding a little bit, then you will have never this problem. You have covered the edges, and this is a fantastic, quick and easy trick. Yes, then open the padding, and moisture the surface so as you think you need time to apply. When you spray water, you have the longest time to apply this tape, 5 or 6 minutes. But when you remove this fiberglass substrate fabric and put it into the water and squeeze it, then you can reduce the time until 1 or 2 minutes. Yes, then apply this splint, fold back the ends or cut it. It's up to the time you have. And the flexion line palmar line from your hand. Then wrap the bandage around the extremity and the splint themselves. Modeling is so important. Yes, the same with POP. POP casts similar modeling. Fix it for the next 1, 2, 3 minutes. It's up to the moisture, what you prefer. And yes, and then it's finished. That's it. And at the end, you have a clean room and a clean patient, and you are also clean. Okay, let's talk about not only the dorsal splint. We have also a second version. It means dorsal and volar splint. Here, the sandwich version. It looks like a sandwich. What we do is we measure the length from the knuckle joints to the elbow flexion line. Then we stretch the padding. Again, this is the same procedure. Then we open the padding. And cut the fiberglass material in the middle. Then, yeah, this is what you cannot see here. I grab the ends, that means with the right hand here, fiberglass and padding, with the left hand here. And then I stretch the padding a little bit more. And then I have here a little bit more space, 2 or 3 centimeters. And then I fold back the second layer from the padding, close the padding, and cut the padding until the last 1 centimeter. So, and the last 1 centimeter is the padding here between thumb and index finger. And then I apply this splint from the dorsal and the volar side from the forearm and wrap the bandage around the forearm. This technique, meanwhile, it's coming more and more, or find more and more interest in the world, because we have stability from two parts of the forearm. That means here it doesn't matter if you have a Colles or a Smith fracture. You have high stability in your wrist, similar like a circular application, but it isn't. Every time when you have a swelling process behind of this application, you can open it easily. Let me tell you a little bit more about this application. Normally, when the patient has a radius fracture, and we apply a dorsal or volar splint on one side, we wrap the bandage around it. So next day or in the night, the patient gets a swelling process, and we have to remove the bandage and we have to apply a new bandage. In this case, we need somebody who stretch the fingers and fix their arm, their upper arm, to keep the fracture in the right position. Otherwise, it could be the fracture can change the position, and and then you fix the new application in the wrong position from the fracture themselves. That means normally we need two people, one who fix the fingers on the arm and the other who change the splint, to make sure that the fracture stay in the same position. Okay, but with this application, we are so happy. Let's start with point number one. Let's say you're sleeping in your bed and you have only a dorsal splint, and on the other side you have only a bandage, and then you turn your body over your hand and you flex your hand, and in this moment you flex your hand through the bandage, not through a splint material. And in this moment, you get the movement, a small movement, micro movement in your fracture, and you feel the crepitation and you feel pain. And then you wake up because it hurts so much. This is not so comfortable. It works. We did it in the past a lot, but for the patient, it's not so comfortable. And we have patients, they have a bad. That means the patient doesn't do this, what we say them. The patient is doing more. That means when you have only on one side a bandage, on the other side only the splint, the patient can move the wrist through the bandage much better than through the splint. All these points has also children. When you have children with the radius fracture, is this application from both sides so good, is so safe and so comfortable. Yes, you can believe me, this is really good. But then I come to the last point. When you wrap the bandage around the arm with two splints, then you get swelling process. You can change the bandage alone. You don't need a second people, because what I do is I cut with the scissor the bandage here 10 centimeters, 10 or 15 centimeters. Then I stop with the scissor. I open a little bit this space, a little bit more here, this slab here, and then I start with the second bandage here, 1-2 layers, and then I stop, and then I cut a little bit more, open 2 layers a little bit further, and wrap again. I come with the bandage now closer to the scissor, and then I cut more and come and wrap the bandage closer. So at the end, I don't need more than 1 minute. I have changed the bandage. The patient has more space between the layers, and the problem is never there. And I could treat it alone without helping from a second people. Yes, all this is why we like, meanwhile, this application. Also, when you fix your fingers in the extension system, it's also fantastic to apply this system on the wrist. Okay, so, and here, the last one is, I will show you also for the radius fracture what you can do. You can also say, okay, sandwich the stability is not high enough. I need more stability. Okay, no problem. Then you have to take the prelude, the fiberglass in the bigger size, 12.5 or 15 centimeter. Then cut, fold it on in the length. That means 30% overlap. Cut here a little bit, a little hole inside. Oh, no, sorry. Moment. So, cut here a hole here inside, and then open it, and then you see here on the flexion line here, and then you see you have a hole here, and then apply this tape with a small. It's up to you what you prefer, with the small or the biggest part of the splint, volar or dorsal. You can change it wherever you want, and you can also never cut on the wrong side the hole, but you have on both sides the same padding material. You can treat the left and the right arm and with the same cutting technique. Yes, and then apply the bandage around the arm, apply it from the radial side, and then you have also a sandwich effect. This is the highest stability we can get with a splint. This is, I like it, but I like it only when I don't expect a swelling process. You can imagine the patient get a swelling process in the forearm, and then you have to remove the bandage, but the splint is as it is. That means you have to open the splint a little bit more, that the forearm has more space, and then you have to wrap the bandage again. In this case, you need also a second people who fix the arm, because you have to open the cast material. Yeah, that's what I mean. Okay, that's why I like it, but I like it only when you don't expect the swelling process. So it's only for you to see what options do you have with this material. And then let's come to a lower limb. Let's come to the ankle fracture. Let's say we talk about ABC fracture or whatever, or it is an inflammation. Not every time it's necessary to treat the ankle with a splint only when you have a fracture. You can have a wound. For example, a dog has bite you in your foot or whatever, or you have a different, or after operation you need fixation. And then we have two options. We have the L-shape version, and the L-shape version is the fastest and easiest version. And here you see the modern techniques. We show this the last 3 years outside, and the people are really, really happy with this technique. Let me explain why. When you, at first, you have to apply a version, it's big enough, wide enough to cover the calf here, so that you have a good stability, 12.5 or 15 or 20 centimeters. But here, when you have 15 centimeters, what do you do at the heel? You have 15 centimeters, but the heel is 8 centimeters, for example. What do we do with the overlap? In the past, we press it together and fold it back and wrap it into the bandage. But when you do here, or you have PUP material, PUP material is coming from here to here, so in the oblique shape, whatever. Every time we come closer to the malleole, or we cover the malleole themselves. When you get the swelling process and you have not enough padding behind of this, then it could be you get pressure problems with the prominent part of the bone from the malleoles and the materials in this area. It could be, not every time, but we see these problems really, really often. So, but we have thinking, what can we do to prevent all these problems? We measure the right length, we moisten the surface, we close the padding, and then you see what we do. We fold back the fiberglass splint with the padding themselves, fix it with the tape, and then we turn this here, this is the inside and this is the outside. Okay, this is for your understanding. This is outside, this is inside. The foot is here, not here. And then we apply this technique on the in the foot and ankle and lower limb area, and then you see you have here double material. This is a fantastic strategy to do this, and you have this stability. This is the stability like to build a bridge outside. Right? You have to think, I want to have not so much weight, high stability, and then you have the stability from the middle of the calf to the middle on the foot, from here to here, because we fold it back, and then with the bandage. And when you get the swelling process later, no problem, you have here no splint. That means you have a high stability, but you have no splint, and you have only the bandage themselves. When you need more stability for the first minutes, you can also apply a second bandage in the U shape here, bring the foot in 90 degree, fix the bandage from the plantar side to the proximal end of the leg, and fix it with the bandage. And then you have a good fixation for the foot in 90 degree. Yes, this is more and more people like it to see what's possible to get high stability and no problems anymore in this area here we have. And at least let me explain you what you can do when you need more stability. The patient put the foot on the floor, on the bottom. Okay, it's not allowed, but mostly the patient are doing this too. Then you can, or you have a dislocated fracture. After operation, you need a high stability, whatever. And we don't talk about the indications now. We talk about just the technique themselves. This is the U-shape technique. That means we measure the length in the U shape from the hollow of the knee, from the medial side to the lateral side. Then this picture is not right. Normally we take a bigger size, a double size like this. Okay, the graphic designer did it wrong here. You see, this is too small. A bigger size, 10 or 12 centimeters, and then we apply it in the U shape because normally the forefoot is free. To get more stability in the forefoot, we open the padding. Then we take a second part of this material. Open the padding here too, covered in the size from the foam, and the shape, sorry, from the toes, and then we put this slab here into this slab. This part is coming together with this part, and then you have here this overlap, and this is the part here from the forefoot. You see it here. And then we applied completely this technique and wrap it with the bandage, and then you have a good fixation. This is really, let me say, believe me, this is too small, a bigger size, and then you cover the Achilles tendon. The heel is free here. This is a big advantage. And you cover the plantar side from your foot, and then you have when you remove the bandage, it looks like a boot. And this is fantastic. Your ankle has no more the chance to move inside, and in each direction you cannot move the ankle, and this is fantastic. And the big advantage is the heel is free. When you have problems with pressure points or with a blister or whatever on the heel, then you will have never problems with this application here on the heel. Yes. Okay, this is what I want to show you and explain you what is possible. Meanwhile, on two joints, wrist and ankle, we can do more. You have seen it with the modern cast splinting material. Yes. Okay, then I'm finished with my presentation and my explanation, and you will find also most of the application on YouTube. When you put on YouTube, Sudhir, you must help me, or you can send out also the link for YouTube for the people outside, that they can look the videos also on YouTube from BSN SCT, how to apply this cast on the right way.
Thank you, Olaf, for sharing the novel splinting techniques. Thank you very much. Now I would request all the panel members to share their thoughts on the splinting technique shared by the speaker. To start off with, I would request Dr. Klaus Dresing to give his comments.
So first of all, thank you very much, Olaf, for your presentation. I think synthetic materials are in many parts of trauma care and soft tissue care the future. But first, I want to mention that overall we have to look to the fracture or the injury itself. So there are some indications for non-operative treatment and there are some indications for operative treatment. So first we have to decide which kind of fracture we have. So I think in most of the countries the POP is the gold standard for fracture fixation, and especially if you have to do a reduction, then the POP is everywhere in the world the gold standard. And yes, you are right, with POP there are some problems, there are also advantages, but we also have to look to the availability of synthetic casts all over the world. So in those countries, especially those who are supported by AO Alliance, many of the synthetic casts are not available. So POP is the gold standard there. If we look to...
I think, Klaus, sorry, I'm absolutely agree with you, but I think that the point from this webinar was to give an overview what is possible with splinting materials in the future and in our countries, that the other countries can see what they could do, if it's possible or not. Otherwise, I agree with you, when they have no splinting, to buy the splinting materials, then they don't have it. That's true, yes.
So I personally, I'm very in favor with the synthetic casting materials, no problem. But if we look to evidence-based medicine, we have to say that evidence medicine does not support the synthetic cast materials. And also, if you look to POP, the evidence is not very high. So, but if we look to modern casting materials, I agree with you that in many parts of the world and also in many indications, synthetic cast material is a quite good option. And but we have always be aware, if we have a fracture, and if we have a stable fracture, then synthetic casting material is no problem, and we can, as we have called it, you can do primary definitive fracture care with synthetic cast materials, especially in children, because there you need no cast saw. You can take the scissors, so it's very optimal to use these materials. And I think in many indications, the synthetic cast material is the optimum in the future. That's it.
Thank you, Dr. Klaus. Now we request Dr. Nandkishore S Laud to share his thoughts.
I think, thank you, Dr. Olaf. It was a very interesting presentation. I do agree with you. Now, my feeling is that there are three issues in using this cast, which is the future splint material. And not only that, it is initially the pre-operative or definitive or even post-operative or physiotherapy. My only feeling is that in most of the world, particularly if we say India, Bangladesh, and I don't know, Dr. Bisht will say about Nepal, is the cost. And that cost is one of the issues. So if you are going to use it as definitive care in stable fractures, then probably it has a merit. Now, what our experience has been that now you have shown a new material which is moldable, which is nice, but the old one was very difficult to remove. And a lot of people had two things. They did not know the technique properly. They developed pressure sores around the ankle, also around the wrist. So I have a feeling that this is the material of tomorrow, which you have to use. But for my younger colleagues who are here, I would say that do not forget the plaster technique. The art of reduction, and as a sculptor, you learn to be a sculptor if you use the plaster very well. And I can tell you that the way he has shown, with 1.5 bandage of about 4 inches, you can give an excellent distal radius cast, very well molded in the front and side. The question is, of course, as I said, you have to move because patient need it today. Patient asked for it. That's what is happening today, that we need something which is good, particularly the people. So I would suggest 4 things. That choose a patient, identify that this is a definitive treatment or pre-operative. Whether you need a surgery and stability, so are you going to use under splint? Then you don't have to have too much of the stability coming in. Will it reduce edema and everything? Start, if I decided that it's a definitive treatment, then the technique which I show is absolutely correct. And in stable fractures, it works very well. It's very light and very easy to do exercise. But the care has to be taken to check mainly the pressure points. And I'm particularly worried about the distal radioulnar joint, because many times you have in people, in old ladies with a thin skin, your pressure shows there. So I think I would, in those cases, instead of putting in the skin, I would use soft roll, which is a good pressed cotton, and which helps me to have a better purchase. It's patient friendly, it's light, and it's very good. So I think in indicated case, explain to your patient, find out what is his possibility, but try to learn and do good technique. Dr. Olaf, I have my little reservations about ankle fractures. And ankle fractures today is, unless you are definite that it is a stable fracture on reduction, because there are so many different injuries. Mainly in a low velocity injury, undisplaced fractures, or you reduced it, you can use it. But I think in ankle fractures, you have to be extremely careful, particularly the 3 Weber series you showed. I think those are cases will be only managed by surgery. They cannot be managed. However, post-surgery, I think I would use what you have shown for the ankle. I would definitely use it to reduce edema, so that at least for 10 to 12, 15 days, because post-surgery edema is the biggest issue in ankle mobilization fractures. And positioning is extremely important. So I think everything has a place, how you do it in the right manner, in the right indication, and learn how to do it. So I'm quite impressed, and I think it should be done. But for my young people, please don't throw away plaster. Learn how to do it. You'll become a better person, and will find it easy to use this technique, because you become innovative when you use the plaster. Thank you for your presentation. I appreciate it.
Thank you, Dr. Laud. Now I would request Dr. Rishi Bisht to share his thoughts.
Thank you all for your wonderful presentation. I would just like to highlight, principally a few things about your presentation. Well, and this is for all the participants. Well, what you mentioned about this sandwich slab, I think, well, that's one of the perfect trade-offs between a cast and a slab. It gives integrity, and at the same time, it has advantages of slab. So I think that's somewhere, a bit of a trade-off. That's what I want to highlight to all the participants. And again, in your ankle presentation, you mentioned about the pressure points. Yes, for everyone, pressure points are the key factor. Whatever you want to do, you want to put either a slab or a cast. Well, pressure points are the key factors. Now, coming to cast versus plaster of Paris versus synthetic. Well, it's an ongoing discussion, and a lot of things, especially in our part of the world, India, Nepal, Bangladesh, as Dr. Laud has already mentioned, is determined by the cost factor. Okay. And the patients in our part of the world, we have certain kind of patients, where they come to the hospital and they ask the doctor, I want the most expensive thing. So sometimes, our treatment is dictated by the choice of the patients as well. So synthetic versus plaster of Paris. But yes, plaster of Paris does have, place, especially in pediatric fractures. Professor Klaus also mentioned a few points regarding those. And I think, at the end of the day, if you are confident with what you are doing, it's plaster of Paris versus synthetic, it goes either ways.
Yes, I think the reason, because we are stay in the moment here with such a material we have, is that not only the company is develop the materials, we get also the questions from the market, and they say, we need a modern material. We need, can you change this material a little bit, so there. And that's why we stay now here with this material what we have. Yes, but I agree with you. It's not for everybody. It's not for everything. But I'm happy that we have different choices. We have also different patients. We have children, sport athletes, non-compliant patients. We have elderly people or whatever. And we have, meanwhile, for everybody, the right treatment. We have poor, we have rich people, we have everything. Yeah.
You're right, because if you say the 10% rich people of India will be population of Germany. 10%. But I have a feeling that in children,
yeah.
And in women, particularly young women who go to colleges now, they do not accept the plaster. They want something new. And second thing is, they ruin the plaster by keep on writing all the things and then mess it up. So in those cases, I explained to them it's a cost effective to use the synthetic cast, because they don't, even if they write something or pour something, nothing happens. Otherwise, I have to change the plaster very frequently, and that becomes far more expensive than So they are happy, and Dr. Bisht said that it is purely, people read internet today. People want to do the treatment by reading internet. Now, I don't know why have you taken education for 35 years, because if you can treat with internet, what can you do? But that's how it is. Yeah, yes.
I absolutely agree with you. I see this also the last years I did the training in China, and I see that also the people are, some people, it's not only the rich people they are willing to pay the money. No, also the middle class people, they're coming with the children and say, oh no, POP, I know this from whatever, from the past. And no, I want that my children will get the best one. And they are willing to pay until $200. This is so much for them, but they're saying, okay, I spent the money for my children, that my children will get the best treatment. And yes, this is what I see. Not everybody, but I see it outside when they see the advantage from this treatment. Yes.
So it's a very
Thank you, Olaf. Yeah. Thank you, Dr. Bisht, and thank you, Dr. Laud. In the interest of time, we'll move on to the next segment of the session. So before we move on to the question answer session, there's an interesting clinical case presentation by Dr. Laud on distal radius fracture management.
Yeah.
So while we load the presentation on the screen, I would request Dr. Laud to take over.
I think this a case which comes and there is a dilemma. Today, this terminology of distal radius fracture is known as CIDR, comminuted distal intra-articular fracture. It is supposed to be an intra-articular. And today, once you say intra-articular, then you have to restore total anatomic restoration. And then you have newer and newer fragment-specific fixations. I'm very impressed with it, but my understanding is very different. What I feel is I judge every fragment. I judge the stability of the fracture. I take a distraction view. And if I get two fragments with a small combination, I feel I can interlock it. And if I interlock it and do the reduction, and after having done the reduction, I move the fracture. If it doesn't move, then it is stable. I'm not worried. And if that is stable, then I give a cast. Second, I do not do the old teaching of ulnar deviation and palmar flexion. I do not think the positioning of cast reduces the fracture. The fracture is reduced by the surgeon, and surgeon assures that the fracture is stable on the table. So if it is unstable and displaces, some fracture may displace after 10 days. That's a different story. That's why I always check on 10 days. But if I get, then I'll show you an intra-articular fracture. And here also I'm going to discuss with the patient, because you have to operate, and there are problems also related with operate, the cost, the time, the infection. So keep all this in mind. But as a surgeon, don't forget the art of reduction. Don't forget the art of analyzing the fracture. So can I have the next slide, please? Now look at this. Dr. Olaf, what would you do? Dr. Bisht, what would you do? Dr. Klaus?
Since I was, I did my residency probably in era different than yours. I would go for an operative treatment. This is an intra-articular fracture. I think I would go for operative treatment.
Okay.
So we would do a CT scan of all articular fractures, and I think this is for operative treatment indication.
Yeah, right. That's right. I also said that it is unstable, but I discussed with the patient. Then what I feel, I see that it's mainly a step intra-articular, and second instability is if you see the avulsion fracture of the ulnar styloid and a depression fracture. And we always take a traction view and find out. So I said that before you do that, Dr. Crawford says correct. We have to do CT scan, but many times in our country at many places CT scan is not available. So a lot of people will be there. So I will tell them that if you can't do that, do a traction view, but do a reduction. And if you in the reduction in 3 dimensions, if you get that you have restored the anatomy, and also the radio-ulnar, radio-carpal, and the radio-height, if you are restored, then probably move it. And if you do not get it and doesn't move, then probably the stable fracture. Talk to the patient, because we do it under the block. Now, next slide. So, give the next slide. This is the post-reduction. And look at the whole alignment of the fracture. No step. There is some amount of scapholundar dissociation, but I'm not convinced. Okay? But complete restoration of radio-ulnar joint. There is no depression at all. Now, this has a very good chance. Only thing which I felt, if you see a small volar fragment. Now, I would talk to the patient and the relation that, he may do better with surgery, but he has a good chance of healing. We'll have to assess after 10 days. You have to be very, very, very honest with your patient, because you should believe that most reliable and less complicated treatment is the non-operative treatment. And why I'm saying you, I'll tell you at the end. Because if you see volarly, there is very small fragment. So next, show the next slide. That's how it was. You could see a very small volar this. Okay. Now when he came, I told him that you are going to have some restriction and some problem, because I felt where there was a volar, some luxation. Now, when he showed his function, I was taken aback, because I had to tell him, you are not a very well-to-do person, and show the result. Show the next class. That is his result. full function. And when he came back again, he can lift 50 kg. No tingling numbness. So I think as a surgeons, when we make up a mind, there have to be four things. Our ability to put the fracture right, our ability to analyze the fracture, and Dr. Klaus said that do additional investigation if you feel doubtful, our assessment after the reduction, and then at the end of reduction, I would say that do not put them in ulnar deviation and flexion, maintain that stability in 10 degrees of dorsiflexion, and then give a cast. Because try to make a fist with ulnar deviation and palmar flexion, will find it very difficult. Restoration function becomes very difficult. But if you put in normal position, you will be surprised that they retain the function extremely well. So one could argue on this case anyway, but I showed this case from this point of view that in our country, as surgeons, it's very different in the Western world because the patient will ask you 100 questions. Many people from well-to-do ask me 100 questions, but the patient who is not so well-to-do, patient who can be treated cost-effectively. And that's the reason I brought this case to you, that it's a patient, his fracture, surgeon's ability to treat and get function, not his pocket. That's I have learned in my experience. So I would like to have your comments.
Thank you, Dr. Laud, for sharing an interesting case. So now we move on to the next session of the program, which is Q&A session. So I would like to address this question to Dr. Laud.
Yes.
This question is from Dr. Neeraj Malhotra. This question is, in fractures which affects metacarpals and phalanges, what are the ideal splint techniques to be adopted?
I think there is, we have device for metacarpal fractures which are aligned and stable. You have to make them stable. Non-comminuted transverse fracture with less soft tissue injury we give known as functional cast. What we do is we maintain the MP joint in flexion and PIP joint in extension, and put a dorsal slab coming from the PIP joint going on to the MP joint and go on to the wrist, a dorsal slab. And then, as Dr. Olaf said, put in the anterior slab and maintain the patient. And you will be surprised that non-comminuted stable fractures, metacarpals, heal extremely well. But the functional cast, this should be your position. This should be your position. So after you give the cast, if you have covered this, you should be able to do this. You should be able to do this, because when you remove the cast, all that you have to do is this. Worst thing to do is to give a plaster like this, because once you get the MP joint which in this position, it's extremely difficult to get them down. And this is an excellent functional position for the metacarpal fractures. And if you have phalangeal fractures, we can extend it right up to here. Displaced fractures in metacarpal, we use also K-wire and a strap. So you can find out if you don't get much displacement, alignment is good, length of third metacarpal is very good, then you can give the functional cast. Otherwise, reduce it, use a K-wire to hold it, particularly for phalanges, and give this functional cast in the position I told you. And you will be surprised how within 6 weeks they get excellent result.
Thank you, Dr. Laud. Any comments from the speaker and other panel members?
Totally agree.
Okay, so I move on to the next question. This question is addressed to Dr. Klaus Dresing. His question is, what is the role of splinting in non-fracture cases? For example, in patients with joint dislocation, joint arthritis, or soft tissue injuries?
Sorry, I have not understood the first part of the question.
So his question is, what is the role of splinting in non-fracture cases? For example, joint dislocation, arthritis, and soft tissue.
So I think if you have a luxation and you have a reduction, then you always have an injury of the ligaments and the joints. So you have you need a stabilization of the joint for a certain time of 4 weeks or 6 weeks. But if you have a soft tissue injury, it's only supporting the healing process. And I think if you have a soft tissue problem, you need to look to the wound, for example, every day. And there, really, the synthetic cast material is better than plaster of Paris because it's much more hygienic and it's easier to apply these synthetic casts to wounds, for extremities with wounds.
Yes. Okay. One point is also important. Synthetic cast material, the most of them are breathable. And that means if you're sweating, you prevent skin maceration also on the wound. And this is good also when you cover the wound with the wound dressing and with the synthetic splint. Yes. This is also a point I forgot to explain in my presentation. Yeah,
I think when these dislocations come, they are, as Dr. Prof said, they are multiple injuries, ligaments as well as the cartilage and similar cartilage, maybe knee, even an ankle, and small chips of fracture. So you first have to give them splint and medication to reduce the swelling. You can't do the diagnosis on first day. There's a pain injury. And I think this kind of splints, today in India, for a knee, you have modular new splints. Then you just put the knee in and stab the splint. It's removable. Because the main is you can't come to a final first diagnosis on that day itself. Because it could be bone or ligamentous injury, you may need CT scan, you may require an MRI also. So as a primary splint to give pain relief, also to reduce the swelling and inflammation, it's better to use the splint. Now, I will only caution about the severe dislocations of ankle and knee, where what you see on first day is not the same story. Particularly an ankle, by the 4th or 5th day, you start getting skin changes or blisters. And that's the reason that a good splinting, which can be removed and you can observe, probably has a very big role to play. Because I would like to know from the class when they operate, but my own practice, I do not rush with the surgery same day if I feel that there is associated severe injury. Because I'm not too sure about diagnosis. I'm also not too sure as to what would happen if I do surgery. So I would rather splint it, elevate it, reduce the swelling, relieve pain, plan the whole treatment, and then do it. But let me again say, even after surgery, I would continue to use the splint, remove it 3-4 times a day, give active and passive physiotherapy, and give it back. And my experience, patients have been extremely happy. Those patients whom we treated like this, but all those who were just left for a pressure bandage, they were miserable.
Okay, Dr. Laud. So moving on to the next question. This is from Dr. Sumit. It is addressed to Klaus Dresing. This question is, in terms of static synthetic splints, there are multiple options to choose from, be it fiberglass, be it POP, or there could be pre-padded fiberglass splints, or thermoplastic, or prefabricated. So how does a clinician choose among these multiple options available? Dr. Klaus.
So I think that depends on the country where you live. So the basic splinter material all over the world, I think, is POP. And then you have to look if you have semi-rigid casting or rigid casting synthetic material, or if you have thermoplastic materials. So I think that it depends on your country and the availability. So I think that for a normal hospital, yes, the basic is POP. And then you choose one material And with this, you can nearly, after you are trained, do everything. So if it's possible to use this pre-padded synthetic cast material, it's great. But if you do not have the possibility, then you need padding and synthetic cast material to produce custom-made splints or casts. I think if you look to around the world, thermoplastic material often is not the best choice because you need machines to heat water or to put the material in steam or whatever, and then you can mold it. But then afterwards you have something like a very rigid material. So I think semi-rigid casting material or this padded fiberglass material is better.
Thank you, Dr. Klaus. Any comments from the rest of the panel members?
I think it all depends. You see, in India particularly, we have been now using the newer material, thermoplastic material. But I personally feel that the delta cast is quite popular in India. You know, it all depends on how you have the friends, how you do the marketing, and how do you do the thing. But the fact is, anything which is really about Dr. Olaf Laud, and I think it is a big application because if you can slit it, if you can cut it, then you know you can make excellent splints by which using an elastic glove, you can have two here, and make it into a wonderful splint, mobile splint. That's the merit of what he has said. So what I've learned observing him is that where we have a lot of neglected trauma, we get a lot of patients who do not cooperate. And that's what I bought some splints to show how we can train the patient to do that. That's why Dr. Olaf's material to me looks very encouraging in the sense that we can really extend its use toward the neglected trauma, toward the contracture correction, towards the post-burn corrections. You know, India has a lot of problems. We still get burns. You know, I don't know whether you get them, but we still get them burns. And their hand is the main thing. So what we do is we just pin them like this. And if you put a material like this and then slowly mobilize him and do very early skin grafting, and you'll be surprised how a devastated hand we can restore the whole function. So I think Dr. Olaf's material, we should have a look at it. And you know, I have my colleague known, Dr. Sudhir Warrior, who is a hand surgeon. He's a brilliant surgeon. And I think you should see him because he might be able to make out some very innovative splints for finger hand, for hand and thumb injuries and, you know, the Rolando fractures. I think it's a very good thing we should do it. Because theatre time is also very important now. If you are able to save the theatre time and AC, if you see, then it's still very good.
Thank you, Dr. Laud. I think we're already past 10 minutes past 2 o'clock. So we might have to continue for another 5 minutes to address some of the questions from participants. Hope it is okay with the speaker and the panel members.
It's okay, yes, go ahead.
Yeah. So the next question is addressed to Dr. Rishi Bisht. The question is from Dr. Selvaraj. His question is, what is the role of splinting in pre-operative and post-operative immobilization?
Well, in pre-operative cases, well, again, the main role of splinting is to take care of the pain and to prevent further complications. The further complications that can occur by the displacement of the fractures. You might want to avoid some neurovascular injuries. But then once you come to a post-operative phase, it's much more concerned with the rehabilitation. Dr. Laud already mentioned that, like in the post-operative phase, the way you use a splint is totally different from the way you use pre-operative, because you're basically concerned about taking the splint on and off and doing the physical therapy, all that. So in pre-operatively, you are basically concerned more about the damage control and the pain management, whereas in the post-operative, the use of the splints is basically the rehabilitative phase.
One single advantage of the splinting and elevation and positioning is reduction of edema. See, post-operative edema is a big challenge. And if you neglect that and get stiffness, to get function, particularly hand and ankle, is so difficult. Now, examine the case, you have done a wonderful job, and the patient has a slight plantar flexion contracture, is an equinus. You've done a brilliant surgery of involving the ankle and foot. And you say that your X-ray looks very good, but patient starts walking, he has a problem. So positioning of the extremity is post-operatively. Pre-operatively, if you do, pain relief, elevation, reduction of edema, better tissues, and observation. And post-operatively, it helps you to a great extent. We have compared the patient where you use only elastic bandage and a splint. And those patients who use splint were much more happier, much more happier. And they took a lesser time to restore the function. Now we are going towards the dynamic splints. Means for hand surgeries, we incorporate the elastic bands and then ask them to do their pulsar and tendon surgeries. And you could see phenomenal result because those splints hold it. You move the hand, you don't get any adhesions. Only thing you need to block. For example, if you are doing a finger surgery, you got to block the extension because your flexor tendon will give away. So you could still, what you do is, you can give a splint, put a rubber band and do this. So don't get this, and ultimately the function is very good. So as I said, my practice, I belong to old generation. I think rest and splint is very important. And in my clinic, I have still Robert Thomas splint and Bowler splint. I still have it. I don't know about Dr. Klaus, but I still have it because I feel that they have a role, particularly patients come late. So don't throw everything old. Have a look at it. Sometime it is useful.
Thank you, Dr. Laud and Dr. Bisht. The next question is addressed to Olaf. The question is from Dr. Alok. His question is, in one of your slides, you mentioned the proportion of synthetic material, the major share is occupied by synthetic splints rather than POP material. So his question is, what are the reasons for this major shift in Germany?
Okay, I understand why. What is the reason? Because we prefer synthetic splint compared to POP, right?
He wants to know the question again.
So the question is, he wanted to understand what is the reason for shift in terms of synthetic splint material, moving from POP to synthetic material.
Yes, and the reason was because we shift so much from POP to synthetic splint is the time pressure in the clinic themselves, in the ER room. They say we have more and more patients. We have not so much time. They don't like the mess from POP. They don't like the long setting time from POP. That was all the questions on the company to say we need a material who can make this treatment better than a POP. The POP is not wrong, absolutely, but they say we want to have a material who can have not all these disadvantages, what they mentioned. They have to say mass, wetness, and then the time, and this was the steam. All this was the point to develop materials like splint fiberglass. We have it now. And that's the reason, because the people like it. It's faster, it's much more clean, and it's the weight is important, breathability of so many, and to learn to apply the splint with this material, with the modern material, is not so difficult. That means, in my opinion, it's much more difficult to train the people outside in POP material than in splinting material, because you cannot make so many mistakes with pressure points and whatever. No more with this modern splinting cast material. Yeah, that's the reason, because we have so many friends for splinting, cast splinting in Germany, like POP. Yes, it's getting reduced more and more, but we need it, but no more so much than in the past.
Thank you, Mr. Olaf.
I have to add some points. I think the one of the biggest issues is that most of the people who work in the emergency department are no longer able to apply a plaster cast because the education is very bad now. Yes. And it's much easier, you are right, to apply a synthetic cast, but it's a problem of the hospitals. And the second thing is that there is a huge indication for operative treatment. And so many colleagues think we do not need reduction after injury, we treat all operatively. So why we should apply a plaster after reduction? And that's a trend, but I personally do not favor, because I think if a patient with a dislocated fracture comes to a hospital, to the emergency department, first we need a reduction, then we have to look if we have an operative or non-operative treatment in the next days. But that is a huge problem in Germany. And so I want to add, we as doctors, we as trauma surgeons, we need to know how to apply a splint, a plaster, or synthetic cast. It's not up to the cast technicians to do that. We as surgeons, we have to do the reduction and not the technicians. I'm sorry, Olaf, but I think that is a task, that the task of the doctors to do that. And I see more and more that in German hospitals, young residents are no longer able to apply a plaster cast, and that is not good development. And what Dr. Laud said, he wants that every resident knows how to apply a plaster. And I think it's very essential. And even if you know to reduce a fracture and apply a plaster, then you have better chances in the OR to reduce a fracture.
Yes, absolutely.
Yes, Dr. Klaus. You know, I always believed that a good surgeon is one who knows when not to cut. And a safe surgeon is that who knows when to stop.
Yeah.
So this is what I have learned in my 55 years of practice. And
yes,
I think it's very important. What you said is correct. So younger people should be told that technology is important, because basic concepts of healing have not changed. They're still there. How do you put it?
You see, to treat a fracture in the conservative way is not used. Sarmiento in the past has shown us this also with such a big.
It's more demanding. It's more demanding.
But
you do surgery and forget about it. It doesn't happen.
The anatomy is not changing from the past to now, not so much.
Healing, not changing.
And neither the fracture healing has not changed.
Correct. So I always say, we as orthopedic surgeons, anatomy is important, but we forget physiology, function is vital.
Sarmiento
so do everything, a good-looking X-ray with no function.
I never forget the sentence also from Sarmiento. He said, I don't treat the X-ray picture, I treat the human patient.
Okay.
Yeah. Okay.
So with this, we come to the end of the program. In the interest of time and to respect everyone's time, so we conclude this program. So I would like to thank the speaker and all the panelists, and of course all the participants for making this session a great learning experience. A couple of announcements before we leave. So I would request the participants to share their feedback and any queries which they have about the products in the same question box which you see below the screen. And in case some of your colleagues or your team members are not able to watch this webinar live, they can do so during the next 1 month using the same link. So the link will be active for the next 1 month period. So you can access that link. The recorded webinar will be accessed. So can I request the webmaster to project the slide so that participants can view the link?
Yeah, sure.
And an important announcement about the next webinar, which is happening on 30th May. So the topic for that session would be about casting, about advanced techniques in that, especially focused rigidity casting. And we're also going to talk about the latest advancements which are beneficial to the patients as well as doctors. And driving this session, we have eminent speaker, Mr. Samuel Brown, who is an experienced orthopedic technologist from USA. And we also have panelists joining the session. We have Dr. Jawahar Jetwa, who is a consultant orthopedic surgeon from Ahmedabad, India. We have Dr. Dilshan Munidasa from Sri Lanka, and we have Dr. Jim Harrison from National Health Service, UK. So I would request all the participants to take note of the web link, which is projected here. And I also received some of the questions about showcasing a video of the splinting techniques. So if some of the participants will be sharing your splinting technique videos individually to all the doctors, so please stay tuned. With this, we conclude this program, and thank you very much, and stay home and stay safe.
Okay, thank you. Thank you.
Bye-bye.
Thank you.
All right.